Thank you. In the pediatric population, due to technologies and mitral valve disease with excessive valve must be individually tailored for patients to achieve a proper valve be considered for surgery. A biventricular repair. Otherwise, they go down the single and secondary muscle attachments to improve mobility. Omnis variant we see in the congenital variants in mitral stenosis. The incision is made, and there are two variants, supraannular and intraannular. Supraannular, there's a definite space between the tissue and the leaflets. So it's a very straightforward surgery, provided you take precautions that you don't perforate the leaflets and you do it completely, and recurrent rates are very less. The intra-annular variant, we have personal experience of 1 or 2 cases where they do come back with recurrence, and sometimes they have persistent pulmonary hypertension. So this is a photo of supramitral ring. And the important thing is to differentiate a supramitral ring for a core triatriatum, which is aided by the help of the presence of a left atrial appendage orifice. The finding of an eccentric non-fibrous thickening in the area of the left circumflex coronary indicates a rare variant called supramitral ring, which is indicated earlier should not be resected, since it very likely harbors the coronary artery circumflex. So this is a supramitral ridge. The next and very challenging variant that you deal with in congenital mitral stenosis is parachute mitral valve, where the papillary mice, there's an unequal distribution of cords, one normal and one elongated, or elongated papillary muscle is dispatched to the mitral valve annulus, and the anterolateral papillary muscle is usually abnormal. The clinical presentation is one of mitral stenosis. The surgery is very judgmental, where you split the papillary muscles and the cords judiciously so that you end up with 2 papillary muscles and release as much of the mitral stenosis as possible without producing significant mitral regurgitation. Mitral arcades I found the most challenging finding and have struggled, where we've literally spent significant amounts of clamp time creating very judgmental surgery, where we split the cords and thin out the leaflets and try PML patch enhancements. And the one we did was a baby less than 2 years old, so replacement was off the cards. And a Hammock valve, where all the create intercortical spaces in the posterior mitral leaflet cords. Our first case for presentation is a 1-year-old.
Focus பண்ணுங்க கீழே வைங்க
Common AV canal with bilateral SVCs, with significant MR, a large VSD, and this is a patient with left atrial isomerism, common AV canal, common atrium, double outed right ventricle, VSD, PS. This is the first step in the surgery. We've cannulated both SVCs and IVC, and we are closing the cleft in the left AV valve and making it into a mitral and tricuspid. So this marks the end of the mitral, that marks the free end of the mitral, and that's the tricuspid on that side. Thank you. The anteroposterior relationship of great vessels. So basically, this is another arterial switch. We've been doing quite a few of late, very complex anatomy.
So I can see there's a lot of bypass
We should not do
across.
the Lacombe maneuver.
So if you can get
We'll
slick
do
at
the extensive
these
dissection
congenital
of
valves
the
fast, you
atrium,
save a lot of clamp
and then
time.
we'll do the switch, but bring.
So this is another case of a common AV canal with DORV, again combined lesions. So we repair the cleft of the mitral. Sometimes we don't achieve absolute regurg. That always plays on your mind. You know, you'd like to come out with trivial or mild MR, but sometimes you come out with mild plus, and this is in spite of getting a good cleft closure. So one of the things I was considering listening to Dr. Shiva's talk is whether we should think of doing those commercial plasties or postular annuloplasties. They may help, provided they don't produce any MS.
So this is the cleft aligned. A little more difficult than expected. Usually we get it in one shot. Thank you.
So what we did was we enhanced the anteomitral leaflet patch enhancement of the autologous with an autologous pericardium, and we did a limited posterior partial annuloplasty using pyoproline sized on a size 12 AGA. Post-op echo showed no MS with mild MR and was extubated on the second post-op day and got discharged on the 9th day. This child came back for a 5-year follow-up with mild MR and on no medications. The next case is a 1-year-old child diagnosed at 3 months of age with history of poor weight gain. And echo showed a complete AVSD. And the reason I put this up is this is a routine common AV canal, extubated within 2 hours, developed severe endocarditis MRSA of the left AV valve. The valve was totally blown, had to take back to theater. And this is what I did, an upside down St. Jude 17 valve. And sent the patient back alive and well to Africa, but on acetylene. When we called up to follow up the patient had died from acetylene-related, INR-related complications. They just don't have access to INR blood testing or acetylene controls. So that's why I always emphasize small babies, repair, accept some imperfections, and get out of the theater, live to fight another day. So this was a case, an adult done outside an AV canal, partial AV canal, where they not repaired the cleft. And so all this required is, of course, overcoming the challenges of a reduced anatomy and repairing the cleft. And a congenital surgeon has to deal with rheumatics, which is outside the purview of the talk. But we have a very simplified approach to repairing rheumatic valves, where you put artificial cords to AML, PML patch enhancement, and a posterior canal annuloplasty. And so this is our experience. And the only thing is that our follow-ups are limited because we are a corporate hospital where our cardiologists go to the periphery and do follow-ups. So we don't actually collate data which can stand up to scientific scrutiny. But in private practice, if there's bad news, they'll call you and tell you. So there have been very little phone calls of late with any valves giving trouble. And one of the things we've done is in older children like rheumatics, we don't accept imperfections. If it's a really bad valve, we replace with a mechanical valve, not a bioprosthetic. But if it's a younger child, we really go all out, repair and accept imperfections. The older children, with rheumatics, we repair the valve, provided the valve leaflet tissues are good. Thank you. So in conclusion, surgical management of mitral valve disease in infants and children has a major therapeutic challenge. It poses specific surgical difficulties because of wide spectrum of morphological anomalies. Like I said, it's like dealing with a Rubik's Cube. Mitral valve repair is the preferred technique, allows for valve growth without anticoagulation, and why MBR is not the best option.